this gets something I said before about how healthcare financing, Medicare, Medicaid is different from other mandatory programs. So if you maybe don't be maybe working in the health branch or at USDA or some other Department of Treasury dealing with different programs. These are some examples. Payment on the interest. It's just interest rates times the amount of principal. It's like your mortgage. It doesn't vary that much unless you refinance or borrow more money. Social Security and SNAP, it's the number of people times monthly benefits, right? It doesn't vary all that much. SNAP, it can go up and down a little bit, varies a bit. But healthcare, affected by a lot more factors. Whoa. It's much less constrained, a lot more volatile than a lot of other entitlement programs, which is why, beyond the size of the dollar, size of the pie, it's a much bigger concern for policymakers and government officials who are worried about spending and budgets and deficits. So what affects healthcare spending? Well, it's simply all spending is just price times number of units times dollar of unit gives you total dollars spent. In healthcare, it's number of people spending per person. Some of the sub-factors are aging. The number of people do you age into Medicare? Are you eligible? Medicaid is counter-cyclical. You guys know what that means? Counter-cyclical? Economy goes up, number of poor people goes down, then the Medicaid enrollment goes down. The average median income just went up a big percentage last year. Presumably, maybe the Medicaid enrollment in some of these states is going to go down. It could save the states a lot of money. And how do you model and project that? Enrollment, in pre-ACA, a lot of people were eligible for Medicaid, didn't even enroll, or other sorts of government, other insurance programs. The ACA tried to take care of this, hasn't worked so well, through subsidies and sort of the tax penalty. And what causes spending per person to change? What's covered, what services are paid for, as Stephen mentioned, cost sharing, cost shifting, the intensity of services. Do you get an ultrasound or do you get a CAT scan? If you have something wrong when you go to the hospital. And prices. Charlotte? Did I get that anywhere? This is pharmaceutical pricing. This is.
Adam Fine.
Yeah, Adam Fine. Very good.
He gave a briefing for us in health meeting.
Oh, you work in health? Okay. Yeah. This was well. I'd let you explain this, but I want to go through it very quickly because it's very complicated. The point I want to make on this is that the patient gets the drugs from the pharmacy, who may or may not get it from the manufacturer, may get it from a wholesaler. There's a pharmacy benefit manager who deals with the third-party payer. So the drugs may go just like this or like this, but the money flow and the rebates and the discounts and everything else, and this pharmacy, this wholesaler may also be a managed care organization. There could be lots of different configurations. But so the list price, which nobody really pays, gets adjusted downward by all these kind of negotiations. And there are rebates based upon volume. And there's also new ways I'm going to talk about in terms of value. But it's also, whatever the actual price is, net, what's called net of rebates and discounts, is a lot less than goes to the manufacturer. Because some of it goes here, some of it goes here, whether or not the patient has a copay. Is there anything else?
EpiPen be a medical device, it's not part of it, right?
No, that's a drug.
It is a drug.
Yeah. That's a whole nother,
Sorry.
well, it's a whole other complicated situation because of whether or not it's generic or not. In Medicaid, it's single source, non-innovator, which is kind of like generic. And what the rebates are. That's the whole big thing that somebody's investigating because it was misclassified, because the rebates under Medicaid, if you're a brand drug, it's one level, if you're a generic drug, it's another level, and what I contend they've messed up for the last 20 years, if you're a brand drug, you couldn't raise your prices faster than CPI, the consumer price index, faster than inflation. If you're a generic drug, they never put in that provision for generic drugs. I've been complaining about this for 20 years. Why did they just put an inflation cap on the generic drugs? They finally did it in the ACA or in some other very recent legislation. They said generics can't raise their prices faster than inflation. We wouldn't have had Martin Squirrely and all the other things, or the EpiPen. At least not for Medicaid.
Right.
So a little off track. Some of this stuff's too much fun. What other factors affect healthcare? Diseases and technology. Anybody name a disease that's driving up healthcare costs? in Puerto Rico and Florida? No. Zika, right, Zika, right? What was the Zika of the 1940s?
TV.
Tuberculosis.
No, it's in this picture.
Polio?
Polio, exactly. Projections for costs on polio were through the roof. Everybody was in these iron lungs, which was the technology of the day, right? Technology, disease, driving costs. And then the vaccine came along, technology drove down the expected costs tremendously. How efficient the healthcare is organized, legislation and regulations, adding benefits. What's help on it? I won't ask whether you're in the majority or minority. What's that?
I'm not on health, Hatch's office.
Oh, okay. I won't talk about Hatch-Waxman patents today, don't worry. But, you know, what do you add to Medicare? What do you take away from Medicare? There's other sorts of things that can drive up or drive down costs. Demographics, the population, is it, you know, Medicare? Is it Medicaid? Is it employers? Is it a big old manufacturing company with a lot of older workers, early retirees? Or is it a, you know, a new company with 12, 24-year-olds making the greatest new, you know, app? Their healthcare costs will be a lot less. This is the national health spending version of that Medicare chart I showed before. And nationally, 5% of the population, 50% of the spending. So this red little slice, this blue little slice, equals, this is spending, this is percentage of the population. Conversely, 50% of the population, about 3% of the spending. That's the dot app, you know, iPhone app startup company people down here. You just got to remember this, because any population you pick, there's going to be something like, some spread like this. And it's more dramatic than almost any other program I know of in terms of, you know, versus, like I said, SNAP or other things. So.